Now we come to another session, another rather group of sessions. This will be rheumatology, and this will be diagnosis and management of Jagran syndrome. And for this, we have a wonderful speaker, Dr. Rahul Jain, and we have another wonderful person to introduce Dr. Rahul Jain is Dr. Naveen Dutt. He's an additional professor of pulmonary medicine in AIMS Jodhpur. Over to Dr. Naveen, please. Go ahead with the session.
Thank you, sir. A very good evening to all of you. So, as a pulmonologist, normally we encounter Sjogren syndrome when we are either we are doing the workup of patient who is having ILD, or maybe some patient with Sjogren syndrome who come with persistent cough. So, and undoubtedly, if we see the CTDs, the Sjogren syndrome is one of the important diseases. So today, Dr. Rahul Jain, he is a rheumatologist. He is working as senior consultant in Narayan Multispecialty Hospital, Jaipur, and he is an expert member of APLAR Committee to 2011 for guidelines for the management of rheumatoid arthritis. So without any delay, I would like to invite Dr. Rahul Jain for his presentation on Sjogren syndrome.
Thank you, Dr. Naveen. Good evening, all. First of all, at the outset, I would like to thank Knowledge Forum and Dr. Binawat sir for giving me this opportunity. Today, I'll talk about Sjogren syndrome, how to diagnose and how to manage this Sjogren syndrome. So my tag, basically Sjogren is a very common disorder, as common as rheumatoid arthritis, but usually missed in day-to-day practice because symptoms are very mild. So in other words, if patients are having mild rheumatoid arthritis or mild SLE, then always review those cases as a Sjogren syndrome. So he's the man who first described Sjogren syndrome. Henrik Sjogren, he was a renowned ophthalmologist who first described this term in 1933 on the basis of keratoconjunctivitis sicca and punctate keratitis. So it is a chronic autoimmune disease characterized by lymphocytic infiltration and subsequent destruction of exocrine glands like lacrimal and salivary glands and sometimes parotid glands. So there will be a lymphocytic infiltration, and the clinical manifestation would be glandular, like confined to the glands, or extraglandular, like systemic manifestation. As Dr. Naveen was telling, sometimes patient may present with ILD as a lung involvement. So patients of Sjogren may present as a interstitial lung disease in the form of lymphocytic interstitial pneumonitis or non-specific interstitial pneumonitis. And of course, this disease is also of two types. One is primary and second is secondary. Primary is isolated Sjogren syndrome, which is not associated with any other disease. Though secondary Sjogren is very common as compared to primary, because secondary Sjogren can be associated with rheumatoid and other CTDs like SLE, myositis, and other autoimmune disease like primary biliary cirrhosis, autoimmune hepatitis. So this is very important to know. It is very commonly to secondary to other diseases as compared to primary Sjogren syndrome. So you can see the types of Sjogren syndrome in this pictorial diagram. And usually it is associated with rheumatoid, spondyloarthritis, SLE, mixed connective tissue disorders, systemic sclerosis, and autoimmune myositis. Other organ-specific autoimmune disorders like autoimmune hepatitis, primary biliary cirrhosis, multiple sclerosis, myasthenia gravis may have secondary Sjogren syndrome. So when it appears or when to suspect, usually these patients are of middle-aged females in the perimenopausal age group, nearly about 50 years of age, and female predominance is there. Almost for 9:1 ratio is there, and pathological hallmark is exocrinopathy, which involves lacrimal salivary glands, and clinically it manifests as a mouth dryness of mouth and eyes, as keratoconjunctivitis sicca in eyes and xerostomia in mouth, associated with use fatigability, which is very systemic feature of this primary Sjogren syndrome. They have very extreme fatigability. Sometimes this patient may have only myalgia and fatigability, and other features they don't complain. Only complain is fatigability. And of course, these patients may have joint pain in the form of arthralgia. Arthritis usually of non-erosive arthritis, non-erosive and non-deforming. If patients are initially at the outset I said, if patients of mild RA, if non-deforming RA is long-standing RA, if they are we are dealing with those cases, then those cases we must rule out primary Sjogren syndrome by doing or by taking proper history of this thing, dryness of mouth and eyes, as well as doing certain investigations. So this is a plethora of clinical features. Mostly articular and glandular features are very common, and apart from that, systemic features like pulmonary involvement, constitutional constitutional feature like low-grade fever and fatigability and lymphadenopathy. Patient may have generalized lymphadenopathy, and patient in long term, if they don't we don't treat this patient, they may develop into non-Hodgkin's lymphoma. And in CNS lesions like neurological lesions, mostly peripheral neuropathies are very common, like in the form of axonal demyelinating neuropathy or mononeuritis multiplex. So these are the very common involvement of this extraglandular features. Renal involvement, interstitial nephritis, patient may present as a renal tubular acidosis. Sometimes this patient may present as a hypokalemic periodic paralysis, and patient comes with the quadriplasia, and if we do the serum potassium level and ABG, will show hypokalemia and metabolic acidosis. And if we look for their feet or we take the history of dryness, there will be a history of dryness, and on this thing on legs there will be a purpura. So this condition is called as Waldenstrom purpura, not Waldenstrom macroglomia. This is called as purpura of Waldenstrom, which may precede the onset of Sjogren syndrome or may follow the onset of the Sjogren syndrome. And 15% of the cases of Sjogren may have Raynaud's phenomena also. And in those patients, usually this thing centromere antibody can be present in those patients. So they mimic as systemic sclerosis, but patient will have Raynaud's, and other features are very mild, but antibody will be like I told you, this thing is anti-centromere antibody, but these patients may have Raynaud's with Sicca symptoms. So these are the varied presentation of Sjogren syndrome, and these patients are characterized by symptomatology. If we take the history of these patients, patient will tell about the gritty, sandy feeling in eyes, stinging feeling in whenever they get up early in the morning, difficulty in eye opening. So these are some clue, or we should always ask in our history taking about these features. Dry mouth, patient will have difficulty in swallowing. They always difficulty in chewing dry food. So these are the typical history of Sjogren syndrome. Apart from that, there will be increased cavities in teeth. So there will be a premature loss of teeth. Many of patients, purpura of Waldenstrom, they will have early decay of teeth and associated with purpura of Waldenstrom at their feet. So apart from that, the patient will have sore throat, dry cough, and mouth ulcers, cracked lips, and these are the some features in the form of symptoms and signs. Other features like swollen parotid, these patients may have recurrent parotid swelling, like in 25% of cases unilateral or bilateral involvement is there. If recurrent swelling is there and persistent swelling is there, we always think of to rule out non-Hodgkin's lymphoma, because this is a risk factor for developing lymphoma in long-term patient, long-term this thing. And apart from that, patients usually have joint pain. Joint pain will be in the form of arthralgia or arthritis, but usually of non-erosive or non-deforming. Apart from that, dry nose, there will be crusting of nose. These patients may have epistaxis. So these patients wrongly diagnosed as vasculitis or this thing, but usually this patient will have, if we inquire the history of dryness of mouth or eyes, they will give the history of that. Apart from that, myalgia will be there, and sometimes patient will have low grade fever. And female patient, usually these are the mostly female patients, so they will have vaginal dryness and they will give history of dyspareunia. There will be a difficulty in intercourse. So these are the some symptoms of primary Sjogren's syndrome, and we always ask about all these symptoms. So you can see in this diagram, this cracked, dry, loss of papilla is there at the tongue, and this angular cheilitis will be there. So this is very classical and long-standing disease, which is showing cracked fish ring tongue of primary Sjogren's syndrome. These are the two glandular manifestation of Sjogren's syndrome, and one is this is dryness of eyes, which keratoconjunctivitis sicca manifests as a keratoconjunctivitis sicca. So in this picture diagram, you can see this cracked tongue, fish ring tongue, and severely dry tongue. And in this blepharitis is there. This is a periorbital eyelid edema in upper limb, and apart from that, there will be a gritty sensation in or foreign body like sensation or sand like sensation in eyes in these patients. So coming to the extra glandular manifestation, these manifestations present in 50% of the patients and usually have in the form of systemic features like fatiguability and low grade fever, and in the form of specific organ involvement like periepithelial involvement or extraepithelial involvement. So periepithelial involvement would be lymphocytic infiltration of affected organ like arthritis, interstitial nephritis, liver involvement, or obstructive bronchiolitis. And these features appear early in the disease and usually have benign course. And this extraepithelial will be because of immune complex deposition secondary to ongoing B cell over hyperreactivity, and which will be manifested as palpable purpura, glomerulonephritis, and peripheral neuropathy, usually observed late in the disease and are associated with increased morbidity and risk for development of lymphoma. You can see this extraglandular manifestation like cutaneous because of deposition of immune complex in the form of purpura. This purpura will appear over here, this over shin, and this mimic as a vasculitis. And sometimes this patient presents as renal tubular acidosis also. And 15% of cases may present as Raynaud's. Other features like myositis or myalgia, arthralgia, or synovitis may present as extraglandular features. In lungs, interstitial lung disease or bronchiolitis, especially this interstitial lung disease has a NSIP pattern or lymphocytic infiltrated pneumonitis. So LIP variety of this thing, ILD. And sometimes this patient may present as pancreatitis or autoimmune cholangitis. Whenever they present as an autoimmune cholangitis, we should rule out primary biliary cirrhosis because it is very common with as a secondary to primary biliary cirrhosis. Patient may have secondary Sjogren's syndrome. Pancreatitis, in this patient we should rule out IgG4 disease because this patient may have IgG4 disease. Patient may have autoimmune pancreatitis. In those patients, pancreas will be bulky in IgG4 disease, and this thing in not non-bulky pancreas in primary Sjogren's syndrome. Patient may present as peripheral neuropathy like axonal neuropathy, mononeuritis multiplex, or small fiber neuropathy. How to diagnose? This is a ACR-EULAR classification criteria for primary Sjogren's syndrome, and inclusion criteria is a objective evidence of ocular or oral dryness or suspicion of primary Sjogren's syndrome on the basis of keratoconjunctivitis sicca, early loss of teeth, or xerostomia. In those patients, we should rule out this history of previous head and neck radiation because radiation can lead to secondary Sjogren's syndrome. Active HCV infection can lead to this thing. AIDS, sarcoidosis can present as sicca symptoms. Amyloidosis, graft versus host disease, and IgG4 disease is a close mimicker of primary Sjogren's syndrome, in which there will be objective evidence of dryness of eyes and mouth, and points given will be of 1 and 2 each, this component. And apart from that, two things are there. One is lip biopsy. There will be a focus score of 1 more than focus score of 4 by 4 millimeters square of 3 score is significant. If patient is like focus score of more than 3 is there, then along with symptoms, then definitely it is a disease of primary Sjogren's syndrome. Though this antibodies, anti-SSA or Rho positivity is more important. If patients are having symptoms and signs of dryness along with this anti-SSA Rho positivity, then there is no need of lip biopsy, and we can diagnose those patients on the basis of antibodies and clinical symptoms as a primary Sjogren's syndrome. So we can practice this like objective zero ophthalmia or objective zero ostemia, 1 point each, and anti-SSA antibodies are given 3 points. If patients are having these two components, then definitely it is a primary Sjogren's syndrome. If antibody is negative, but objective evidence of minor this lip biopsy, on lip biopsy, salivary gland, this foci is of 3 points, then definitely it is a primary Sjogren's syndrome. If there is a objective evidence, no objective evidence of zero ophthalmia, xerostomia or negative antibodies, but subjective evidence of dryness is there, then we cannot diagnose them as a Sjogren's syndrome, though we can keep them patient as a probable Sjogren's syndrome. So diagnostic algorithm is if patient is having dryness of mouth of more than 3 months and dryness of mouth for more than 3 months, then we should go for Schirmer test, Rose Bengal staining. Our important test is ANA, because it is an ANA associated disease, so we should look for a ANA on immunofluorescence. If that comes positive, then we should go for anti-Rho and anti-La antibody test on by ELISA. And if they come positive, then we no need to go for lip biopsy. If these tests come negative and there is a high index of suspicion for primary Sjogren's syndrome, then we should go for lip biopsy. And these are the tests like for these MRI, EMG, spine. These are for extra to confirm the extra glandular features of primary Sjogren's syndrome, like for PFT and HRCT or 618 walk test to rule out interstitial lung disease, or ABG to rule out interstitial nephritis. And this is Schirmer test. This is a blotting paper, and we can do in clinical this thing of office and day-to-day clinical practice. If this is put in outer canthus of the eye, if this is this will be wet by, keep it for 5 minutes and wet by this thing by tears, and if it is less than 5 mm, then it is significant, and if it is more than 10 mm, then it is normal. And some autoantibodies are associated with Sjogren's syndrome, though most commonly rheumatoid factor is most common antibody which is present in primary Sjogren's syndrome. But on the basis of rheumatoid factor positivity, we should not label them as a case of rheumatoid arthritis or primary Sjogren's syndrome. We should, whenever there is a patient or having polyarthralgia and they have rheumatoid factor positivity, in those cases we should rule out rheumatoid arthritis or primary Sjogren's syndrome by doing anti-CCP and ANA both the tests. So on the basis of rheumatoid factor, we should not label them as a rheumatoid or primary Sjogren's syndrome. Apart from this anti-SSA, as this was included in diagnostic criteria, though LA positivity is very specific for primary Sjogren's syndrome, but the sensitivity is less, so this SSA positivity was taken as a criteria to diagnose in cases of primary Sjogren's syndrome. So what is the significance of these antibodies? This suggests longer disease duration, and these are associated with extra glandular manifestation, especially vasculitis, because these antibodies form the immune complex deposition and they deposit in the like skin, they manifest as a purpura, or in kidney, so they manifest as a immune complex deposition. So as a glomerulonephritis, and these are associated with higher intensity of salivary gland infiltrates. If these antibodies are positive, it means exocrinopathy is very severe and very long standing. And though there is no direct pathological involvement has been demonstrated, but definitely these are the diagnostic marker for primary Sjogren's syndrome. And you can see this lip biopsy, which is autoimmune epithelitis, and this is a basically lymphocytic infiltration of lip minor salivary glands, and there will be a germinal center also. So this is very diagnostic for primary Sjogren's syndrome, and it suggests as a autoimmune epithelitis. So before coming to the treatment, we should know the pathogenesis. Then only we can deal with this patient with this thing for as a disease-modifying drugs. So pathogenesis is a triad of interplay of hormone deficiency, because these patients are females and they present as perimenopausal area. So there will be a estrogen and progesterone deficiency will be there, or sometimes in premature ovarian failure, these Sicca symptoms will present early before the age of 50. And some environmental factors are there, like viral infection like EBV, this thing is rubella, and CMV virus. So these are the direct causative agent for this thing for primary Sjogren's syndrome. And genetic predisposing for HLA-DR, this thing is for predisposing factor for primary Sjogren's syndrome. So you can see how this disease progress and manifests clinically. So initially there will be an initial insult in the form of environmental, viral or non-viral, and there will be an activation of glandular cells and HLA-DR independent innate immune system, and that will lead to cytokine or chemokine receptor activations, or that will lead to acquired immune system activation in the form of B and T lymphocyte activation. And in this disease, predominantly B lymphocyte activation will be there, and that will lead to increased apoptosis. That increased apoptosis will lead to increased antigenic burden, and that will lead to antigen and antibody immune complex formation. So as the B cell activation will be there, B cell will lead to plasma cell formation, and plasma cell will lead to autoantibody formation. So this how this initiates the pathogenesis of this disease, and this will lead to dysfunctional glands and impaired secretion, which leading to Sicca symptoms. So how this pathogenesis will lead to clinical symptoms? So you can see this, as I told you, genetic factors like HLA-DR and DQ genes will be there. The deficiency for estrogen will lead to production of autoantibodies against exocrine gland, which will lead to lymphocyte infiltration, and B lymphocyte activation, which lead to increased gland size. There will be recurrent parotid swelling or recurrent exocrine gland swelling, and it will lead to formation of autoantibodies, and that will lead to decreased tear production in the form of patient may present clinically as a keratoconjunctivitis Sicca, as dry mouth as xerostomia, and sometimes patient will have nocturnal cough in the form of because of decreased mucus production. And decreased sebum production will lead to dry skin. If we inquire these patients about dry skin, definitely they have dry skin also, but these are the subtle features, and patient usually give answer to this about after asking about leading questions. They don't tell about these Sicca symptoms. So this is also one of the ray diagram for pathogenesis of this thing. There will be a acinar cell injury or cholinergic dysfunction, both that will lead to decreased exocrine function in the patient present as Sicca symptoms. And if there will be a B cell over activation or persistent activation, which will lead to lymphoma, and if this B cell activation lead to autoantibody productions, which will lead to immune complex deposition, which will manifest as a purpura over the skin. So this is also the same, but the important thing is there will be a first innate immune system activation and followed by acquired immune activation in the form of T and B lymphocyte activation. And in innate immune system, there will be an interferon signature, and this interferon is responsible for the fatigability and constitutional features. Apart from that, this B cell overactivation will lead to germinal cell center expansion, and which lead to autoantibodies production. and which will lead to immune complex deposition. So the therapeutic implication of this thing is if we target these B cells, so B cell depletion therapy is very important for refractory cases of primary Sjogren syndrome. So this is the main importance of understanding the pathogenesis of primary Sjogren syndrome. If we target
Dr.
these B cells.
Dr. Rahul,
Yes, sir.
so we have
Yes, sir.
already 16 minutes beyond our time limit.
So sorry, sir, but these are the two last slides, sir. So two
Okay.
last slides. So
Please
therapeutic
hurry.
algorithm for Zika symptoms. Now there comes the treatment. So therapy for Zika symptoms. First step treatment is local treatment, and second step is systemic treatment. So pilocarpine is very important for treatment for Zika symptoms. And nowadays we can give these patients 5 milligram BD or thrice a day. But sometimes these patients may not tolerate these cholinergic drugs and they will have sweating or fevers. So we can reduce the dose. Now other features like this thing, like for dental caries, we can advise for fluoride containing toothpaste, and apart from that, good oral hygiene, to ask our patient to maintain the good oral hygiene by doing recurrent frequent brushings or frequent, and this thing is mouth washes. And this is the last slide, therapeutic algorithm for extra glandular features. Patients are having joint symptoms, the hydroxychloroquine is the first line treatment. Second line treatment is corticosteroid. Third line is methotrexate, and for refractory cases, rituximab. For pulmonary, the same. First line treatment is steroids, followed by azoran, mycophenolate, and rituximab. Renal, the same. Like for if tubular, this thing is potassium and bicarb replacement is important. This patient present as a renal tubular acidosis. For glomerular disease, corticosteroid, cyclophosphamide, mycophenolate, and rituximab. These are the this thing is. And for neurological and life-threatening infection, this thing is rituximab and plasma exchange, because these are mediated by immune complex deposition. So plasma exchange is very important. And rituximab is for all these refractory cases. Rituximab is very important drug. Though hypersensitive reactions with rituximab is a very challenging, a very concern. But those patients who are tolerating well, so rituximab is very good drug, a very good drug to achieve remission in those cases. And last slide is this thing. Second, these are the risk factors for lymphoma, recurrent parotid swelling, organomegaly, purpura, rheumatoid factor positivity, low C4, CD4 lymphocytopenia. And this take-home message is menopausal. This occurs in menopausal females, and 50 years of females are usually they don't give history of Zika symptoms. But we must rule out asking those patients for about Zika symptoms, and there will be history of recurrent parotid swelling, and these patients present as glandular or extraglandular features, and we do ANA or anti-Rho positivity. If these come positive, then lip biopsy is not mandatory. If these test comes negative, then we should go for lip biopsy. We should always keep this this thing is in our mind. These are the patients who can develop lymphoma in long term, this thing. And treatment according to the stage, or according to the organ involvement, or according to the glandular or extraglandular involvement. And rituximab is the mainstay of treatment for refractory long-standing disease, and very important and very effective treatment for these patients. Thank you for your patience here.
Thanks, Dr. Rahul. Very comprehensive presentation. And in paucity of time, we'll not be able to take any questions right now. So, so I think we can go ahead with the next session. Thank you.